not least, Doug Hanel has popularized use of internal distraction plate or internal external fixator. And he's used it for special indications, but now it's starting to creep its way into standard fracture management. Go ahead, Doug.
Hello. So Doug Hanel here in Seattle, Washington. And what I'd like to do is I'd like to talk about distraction plating. And here's my list of disclosures. I am a consultant, paid consultant for a company called Aptus, and the fine print is all the companies that give us significant support at the University of Washington in the Department of Orthopedics, and in the state of Washington, I'm required to list that for you as disclosures, even though it has nothing to do with this talk or other research that I do. Probably the best disclosure that I have is looking at my experience of the last 10 days, or the last 10 years. And as you look at this, in my practice, I've got about 750 distal radius fractures, and in 50 of those cases, I've used a distraction plate technique. And where do you use it, and why do I use it? I use it in patients that have the following: the multiply injured patient, especially those that have associated pelvis fractures that need to use their extremities for carrying themselves about. Those patients that have prolonged ICU stays that I don't want to have fixation exposed in an ICU, and patients that need to use crutches. Also in patients that have limited OR time, especially in the multiply traumatized patient. So I use these in extremely comminuted fractures that I don't think I can control with any single plate, and I use it combined with internal fixation bilateral fractures. There are a number of treatment options that we've talked about and that we've seen, and in this setting, I think that the way that I use them is based on and runs on a principle of treatment that was really popularized by Scott Wolf. He said if you take an external fixture, add pins to it, you have a stronger construct. And if you wanted to make this construct just even a little bit stronger, you'd go back to the work of Fred Behrens. And what the late Fred Behrens said is if I wanted to make any external fixture construct stronger, I would take and I would spread out the fixation pins. And the second thing I'd do is I'd take the crossbar in green and get it as close to the bone as I could. So why don't I just do that? I just move it next to the bar, and that's really what the principle is. The first group of surgeons were Ed Burke and Rick Singer in Detroit, and they use it as their go-to fixation. They presented it at the annual meeting of the American Society of Surgery of the Hand in 1998. They never published their series, but they did publish their technique. There are two articles that deal with this. One is an article that was published by Dave Roosh looking at his Wake Forest experience before he went to Duke. And then my experience here at Harborview using bridge plating or internal distraction plating. Probably the rationale is best described by Dave Roosh. And he said that, an external fixture neutralizes compression forces on the articular surface, but it really provides insufficient stability to immobilize metadiaphyseal fractures. And so using a distraction plate will manage that. Open reduction internal fixation, just using a plate that involves or captures fracture fragments of the distal radius, they're great, but they have insufficient stability of the scaphoid and lunate, especially when you have to be weight-bearing on those particular fractures. So if you're going to use this technique, the way that I do it is I use a radiolucent table. I do use image intensification. I'm maybe one of the last people to continue to use large C-arms just because I think that we get less radiographic or radiation exposure when I have single-shot images. Use a simple fracture table, and I don't use fracture traction that is more than 10 pounds. I don't think you really need to use more than that, especially in a well anesthetized patient, either by regional block or by general anesthesia. The reduction maneuver that we use in all distal radius fractures, no matter how I'm going to treat it, whether a distraction plate or with a roller plate, is a maneuver that was described by John Agee. And this is his reduction maneuver, which is longitudinal traction, palmar translation of the hand relative to the forearm, and slight pronation of the hand relative to the forearm, not the forearm relative to the arm. And that will help you realign your fracture. It'll also demonstrate whether or not you have a stable volar ulnar corner, because if you don't, that reduction maneuver, you'll see the lunate continue volarly into the forearm. And you can use it, and it will reduce large fractures and very comminuted fractures, and provides as much information in that setting as a CT scan for most cases. Here's an article, and I think it's worth reading or noting, by John Agee describing this reduction maneuver. And this would demonstrate the first part of the reduction maneuver and just K-wire fixation of that. Now, this is unstable. This patient has bilateral fractures. This patient also has burns over her forearm, and so I have limited exposure for this particular patient, and I will use distraction techniques. People ask what plate. This isn't about the implant. It is really about a technique of using any fixation plate that you can find applicable. And the series that was presented by David Roosh, he used predominantly 3.5 LC-DC plates. In my practice, I use a plate that is a combination 2.4-2.7 plate. I like to use 2.7 screws. I don't use 2.4 screws in it. Of the available plates, there's actually a plate that Becton made that was passed into the second compartment from proximal to distal. I don't even know if it's available, but it is in the company Biomets has it as part of their fracture fixation. The plates that you see, are the 4 plates that you see on the right, demonstrate a plate that is available through Synthes as a custom plate. The holes each have the ability to have locking screws placed in them, and as I said, I use the 2.7 screws. This plate can be passed through the second compartment or the fourth compartment, and I like to use the second compartment because the screws are collinear, and as I said over and over again, use 2.7 screws instead of 2.4s. Passage of a plate along the radius demonstrates that it is collinear with the radius passing through the second compartment and the second metacarpal. And just passing that plate through an intact retinaculum drives home the point that Dr. Bain talked about with his anatomy. If you have a retinaculum intact, it'll help reduce the inclination both radial and in the sagittal plane using this technique. So this is a plate, and although this happens to be a foam arm, you place the plate over the hand and you project with your image intensification to get a general alignment. Make 2 incisions. The red mark is the outcropping muscles that you are going to pass this through. Proximally, the plate is passed between the extensor carpi radialis longus and brevis, and it's passed to the base of the second metacarpal. You can dissect proximally and find where the extensor carpi radialis longus is inserting onto the radial aspect of the second metacarpal, and you can also see where the passage of the ECRB goes to the third metacarpal. I passed a Carroll tendon passer in this patient, and this happens to be a small patient, but in a longer or a taller patient with longer extremities, you may want to use other devices, and I will use spun wire to use as a passer to get this device up into and through this plane of tissue. So this is a spun wire that is passed, and this happens to be a 20 or an 18 gauge wire that is spun on itself. It's stiff enough to pass through this course. You can use it to then capture your plate, and there it is showing evolving there. It is tied to the plate, this plate, with a wire and then passed proximally, and then the plate is secured. And the first way that you secure the plate is I usually get the distalmost screw on the metacarpal and the proximalmost screw on the metaphysis and screw down with a non-locking screw that lags the plate down to the bone. And then I will augment that by adding a second and third screw. Only one of the screws needs to be a locking screw. If you're trying to save on money, seeing as how the locking screws are so much more expensive than the non-locking screws. And this is the final screws inserted, 2-7 locking screw is put in place, and then you complete the fixation. And this is a typical plate, or a typical patient in our early series. And this particular plate happens to be a titanium plate that is on the Synthes mandibular reconstruction set. The problem with this particular plate is that the scallops on the plate, bone can grow into them, and so it made it difficult to remove it. And although it's good in a pinch, I no longer use it because of the other plate that we have available made out of stainless steel. There's less ingrowth into that plate, and it removes easier. And this is a patient at that. If you look at what is enough, we know from a study that was done by Jonathan Wolf, who's in his orthopedic residency in Cincinnati with Peter Stern. We know that 3 screws at either end is stronger than 2 screws, but 4 screws doesn't make a difference, and so we limit it to 3 screws at both ends. I think that as we evolve and we look at this, here would be a typical case of a bilateral wrist fractures in a patient with associated polytrauma. In this case, I did exactly what Dr. Bain said. Fix the volar side, get it as anatomic as you can, but support the dorsal side with a device. And in this case, we have a plate that goes into the 4th compartment on this side. And on his other side, he's got a combination of a Montesia fracture and a distal radius fracture. Again, we fixed it with a combination of screws and volar plating and then fixation of his fractures. Eventually, at about 12 to 16 weeks after his surgery, we removed the dorsal plates, and this is his radiographs that were taken after 18 months when we did remove his volar implants. And we removed his volar implants mostly at the patient request, and because as his fractures healed, the radialmost ones became prominent and irritating. And this is his postoperative results. So if you look at our cases, in all of our cases, we had 1 infection. We had 2 patients that had extensor lags. We had 1 avulsion of an extensor carpi radialis longus, and that's shown in your slide, and that was using that mandibular reconstruction plate. We did have 2 broken plates, and we did have 2 broken screws, and those were 2 4 screws. I have not had a 2 7 screw break yet. The healing time occurred within 6 to 12 weeks. The quality of the reductions remained appropriate by our standards. The range of motion, despite this prolonged immobilization, was what would be considered acceptable, and their grip strength was about 70% in the patients that we followed, and this continues to be true. There has been a recent report of a patient who, at 12 weeks after their fracture, they felt the plate break. But because of issues of trying to get into positions, they were not able to do so, and they presented 16 weeks postoperatively, or 4 weeks after the plate broke, with ruptures of their extensor tendons. This patient then went on to require reconstruction of her extensor digitorum communis tendons. So I think that this is a technique that has application in a multiply injured patient with limited OR time, in extremely comminuted fractures, and in bilateral fractures. So thank you.
That's excellent, Doug. I want to bring out a few points. You switched to putting it in the 2nd compartment because it's easier to get in there and it provides better ligament ataxis. Because in your early publication, someone noted that you started using a different interval and then switched, right?
Well, we used both intervals, and I was in the first study that we did in Journal of Bone and Joint with Dr. Rouge. We used a 3-5 plate passed into the 4th compartment. The 3-5 plate will not pass through the 2nd compartment. The advantage of using a smaller implant and being able to pass it into the 2nd compartment is that putting a plate on that surface of bone through the 2nd compartment, from the radial diaphysis into the metaphysis, through the retinaculum of the 2nd compartment, and then onto the 2nd metacarpal, you actually do reconstruct by ligament ataxis the radial inclination, and your palmar tilt, just by that alone. And then you can repair your ligaments around that. The other thing that happens is because it flips the plate up off angle by approximately 10 to 15 degrees, mechanically the flexion moment on that particular implant is stronger by that 15-degree rise. So instead of having a plate that happens to be 3 millimeters or 4 millimeters wide, it's the equivalent of having a plate that is 5 or 6 millimeters in breadth, much like an I-beam works.
Gotcha. One final question before the poll questions, Doug. In other talks you've said you started doing this mostly for people in ICU so they could start weight-bearing for pulmonary care. But now it looks like when I was there, you and Chris are starting to use this for elective comminuted fractures. How do you reduce the lunate facet? Ligament ataxis won't reduce the lunate facet. And how do you decide when to use a distraction plate for 3 months versus putting on an X-Fix for 6 weeks with pins?
Well, any place, if we were in that setting that I was going to use a fixator for 6 weeks and pins, I would use a distraction plate for 6 weeks and pins. Some of my partners are very, very liberal with the use of this device, and I am not. I still continue to rely on the techniques that were spoken about before this discussion. And so the easiest way to answer that is I usually will leave my plates in place until patients have all of their digit motion back, all of their pronation, supination back, and are very, very comfortable. And then taking out their plates, this can be done. It does require a second surgery. Randy is right. Patients really don't like doing this, but it can be done very quickly as an outpatient procedure. And the most important thing about it is, and the most surprising thing about it, is the amount of motion that these patients regain. They match my best reductions using volar or fragment-specific fixation.
Yeah, Jesse published a paper on that. If you X-Fix them for 6 weeks, the ultimate range of motion in 1 year is no different as compared to moving them right away. So we're rethinking this whole thing. Roman, I'm going to